சண்முகவேலு சரி, அப்ப நீங்க வெல்கம் பண்ணிடுறீங்களா?
Good morning, everybody.
Hello. Good morning.
நீங்க ஸ்டார்ட் பண்ணிட்டு கூட நீங்க you can look after the other
no problem. Yeah, we can start 11 o'clock.
Rajkumar, good morning.
Good morning, sir.
Good morning. Start பண்ணுங்க
sir. Yes, sir. So I welcome you all on behalf of ISA Tamil Nadu for our online webinar PG exam series 3. Kripa sir, over to you, sir.
Yeah. Thank you, Dr. Sini, our secretary, Tamil Nadu ISA. Good morning, all of you. I welcome all the PG students for this academic phase today, because this is our third webinar in exam going series. This program is the PGs from Coimbatore Medical College will be participating, and I congratulate all the postgraduate students for actively participating in this event. And more than that, today's moderator is Dr. Edward Johnson. We cannot ask for more than Edward Johnson for this program, because he is such an academically active person. So we are very happy to have Dr. Edward Johnson here. And our academic chairperson, Dr. Selvakumar, is very much interested and want to give good quality program for the postgraduate students, and I congratulate him. Last month we attended 2 programs in Tamil on behalf of Tamil Nadu ISA. One is ISA sponsored
sir.
Yeah.
Kripa, unmute yourself.
Yeah. Now audible?
Yes.
Yeah. Last month we had 2 important programs on behalf of Tamil Nadu ISA. One is ISA sponsored CMA program at Chidambaram. It was very well organized, and within short time they registered their society. So it's a lesson for all the ISA city branches. If you need any help for registration of your society, you can contact our ISA Tamil Nadu or ISA Tirunelveli or ISA Chidambaram. We can be able to help you for registering your society. And they released one online journal and YouTube channel, as well as one Tamil poetry book written by Chidambaram President. So it was very well conducted. We appreciate the Chidambaram branch. And the next important thing is, last week we attended an introductory program for anesthesia postgraduate students by ISA Kanyakumari and Department of Anesthesia of Kanyakumari Medical College. It was very well organized by Dr. Edward Johnson, and everybody was thrilled to attend this program. It was such a wonderful faculties and postgraduate students. They attended, and there were very active participation from the postgraduate students of Tamil Nadu as well as from Kerala. So I congratulate both the Department of Anesthesia as well as ISA Kanyakumari for organizing this program. So without wasting much time, we will move on to the program. Today's program, Coimbatore Medical College students will be participating, and next month we are going to have postgraduate students from Kanyakumari Medical College. The topic will be neonatal anesthesia. That details will be revealed by Dr. Selvakumar, our academic chairman. Over to Dr. Selvakumar. Thank you all. Have a happy Sunday. Thank you. Bye.
Good morning, office bearers of Tamil Nadu ISA and the examiner, evergreen examiner, Dr. Edward, my friend. And you cannot ask more than this. He is one of the most active academic person of our India. So, and he's a examiner par excellence in the exams conducted by universities, Kerala, especially Tamil Nadu, and students will definitely get benefited. I thank Coimbatore Medical College who has kept ready their students to take part in this discussion, Dr. Nisha, Dr. Jayakumar, and Dr. Keetana. I should especially thank Dr. Kanagaraj and Dr. Senthilnathan. And there are two ways to learn. One, to participate in the discussion and taking part in the case presentation and learning how the examiner asks the question and how to get trained. And in a way, you can get trained. And another thing is, you can watch others presenting the cases and to a reputed examiner, and then you can listen to them so that what best they are doing and also what mistakes they are making, so that we can learn from that. And this kind of programs will definitely help all the postgraduate students so that they can listen and let them not repeat the same mistakes, or they can repeat the good thing what they have discussed in the exam, and they can get through the exam. I should thank all the persons involved and office bearers of Tamil Nadu and also the participants. Over to the program as such, over to Dr. Edward Johnson to discuss the COPD case who has been posted for a closed fracture femur. Thank you.
Thank you, Sulokkumar. At the outset, I thank the Tamil Nadu ISA for conducting a series of exam series. I had gone through this case report. It was a well-defined case report. I have to thank Dr. Sulokkumar, the academic chairman. So the questions will be a lot. I welcome Coimbatore postgraduates Jayakumar and Nisha. Be cool and try to answer if you know the question. If you don't know the question, let me answer. So it is a common teaching platform. It is not to test your knowledge. So you try to attend so much of questions I will ask. So we will go through the Sulokkumar, you project that case history.
Jayakumar, you can put the second slide. You can share your screen.
Yes.
Maximize it.
Yes, sir.
So that let the others come to know about the case. Second slide.
So Jayakumar, you read that case history.
Okay.
Because it is not displayed for the benefit of all postgraduates, please read the history.
Yeah, you can go for the screen show and then click the second slide, Doctor. It is shared actually. Your first slide is visible.
Yes, sir.
Second slide.
Maximize it. Slideshow. Go for the slideshow.
Yes, sir.
Yeah.
Is it hung up? If it is hung up, you go back and then come back.
Call examiner tell about you. You have to read.
Oh, you got scared. Why you want to collect them today?
Sulokkumar,
Yes.
shall I read the history?
Yes, please.
Yes.
And others,
Here
please mute your computer.
No, from my computer, I am reading. It is not displayed in the webinar. So you made me co-host. Okay. So this we go to second slide. Now you read. Now you read.
Case history: a 68-year-old man was admitted in emergency room with a history of road traffic accident. On examination, he was found to be having closed fracture of right femur. There were no other injuries. He is a known COPD patient suffering from chronic cough, breathlessness, and occasional blood-stained sputum expectoration for the past 6 years. He was taking inhaler therapy on and off. He is also a known hypertensive patient on regular medications. He was taking telmisartan 40 mg once a day and nebivolol 5 mg BD. He is a known diabetic on oral antidiabetics, metformin, and sitagliptin. Vitals on admission: pulse rate 92 per minute, BP of 160 by 90 millimeters of mercury, respiratory rate of 20 per minute. Investigations, HbA1c 7.2, bedside lung function test, where breath holding time 25 seconds, PFR of 350 liter per minute. His X-ray chest is shown below.
Okay, they have given the X-ray and pulmonary function test and flow volume loop also they have given. So go to the second slide. So here is a patient of 68-year-old man. So he is a geriatric patient. I am not going to discuss the geriatric effect of anesthetic complications, but you tell me one finding regarding the respiratory tract, regarding the FRC and closing capacity. What will happen to geriatric patients?
Geriatric patient chest wall complex is reduced due to kyphosis of the thoracic spine. There will be barrel-shaped chest. Regarding parenchyma, the elastic recoiling will be increased because of loss of elastin and collagen. Because of that, closing capacity will be more when compared to the functional residual capacity.
At what age? In lying position and erect position?
In a supine position, by the age of 44 years, the closing capacity is more than the functional residual capacity. And in erect posture, closing capacity is more than functional residual capacity at 66 years.
Very good. So what is the implication regarding anesthesia?
Due to structural changes, since the closing capacity is high, in geriatric patients, the arterial oxygen saturation will be low.
So the shunt fraction, physiological shunt will be increased, so the oxygen saturation will go down. So these patients need higher FAO.
Yes.
Then he is having a closed fracture of right femur. So regarding the closed fracture of right femur, what is the timing of the surgery? How will you classify the timing of surgery? Emergency or urgent?
Emergency surgery, it is the life or limb threatening, so it should be done before 6 hours. Regarding urgent surgery, it should be done between 6 to 24 hours. This surgery comes under since it is a femur fracture, it comes under an urgent surgery. Should be done within a span of 24 to 48 hours.
It's an urgent surgery. It's not a time sensitive. What is time sensitive? What is elective?
Time sensitive surgery means the surgery can be delayed for up to 1 to 6 weeks, sir. Elective surgery, the surgery can be delayed up to 1 year so that the pre-optimization can be done adequately, sir. So
can't we delay this surgery for 1 week?
No, sir, because
vascular compromise.
Yes, sir. It's a long bone fracture and it's a common urgent surgeries. Okay.
So the next the patient is having a COPD patient. So how will you define COPD?
COPD is a chronic obstructive pulmonary disease, sir. That is a common treatable and preventable disease characterized by progressive airflow limitation that is usually progressive and associated with an enhanced chronic inflammatory response to noxious particles, sir. So it incorporates 3 diseases: small airway disease, chronic bronchitis,
noxious particles. Noxious particles.
Cigarettes. Primarily, it is cigarette smoking. Other than that, indoor and outdoor air pollution. Indoor air pollution, biomass fuel. Other than that, textile industry, coal and gold industry also has noxious particle exposures.
Any congenital
alpha-1 antitrypsin deficiencies?
How alpha-1 antitrypsin deficiency produces COPD? Do you know?
Sir, in an exposure to noxious particles, our body has a physiological mechanism to produce elastase through neutrophils. Elastase causes tissue damage. Our body tries to produce alpha-1 antitrypsin to reduce the amount of elastase to reduce tissue damage. When alpha-1 antitrypsin deficiency happens, tissue damage will be more. So person will develop COPD. Sir.
Very good. So what is the component? 3 component you said. What are the?
Chronic bronchitis, emphysema, small airway disease.
Small airway disease. Sometimes it is called asthma overlapping COPD.
Yes.
The important thing is it is preventable and treatable. And the airflow limit, you have said something. Respiratory airflow limit.
Yes, sir.
It is reversible or irreversible?
It is not fully reversible, sir.
So it is irreversible. If it is asthma overlapping COPD, it is partially reversible. Okay. In asthma, it is completely reversible. So the next question they will ask is the difference between COPD and asthma.
COPD occurs in a later age. Asthma occurs in early age. COPD is complete. It has airway as well as parenchymal destruction, but in asthma, it is only airway hyperresponsiveness, which is a hallmark of asthma. In COPD, you have continuous progressive symptoms, but in asthma, it is intermittent symptoms and you have symptom-free intervals also. Neutrophil is the primary component in COPD. Eosinophil is a primary component in asthma. It is CD8 driven in COPD, so response to inhaled steroid is not much. But in case of asthma, it is CD4 driven, so response to inhaled steroid is very much seen.
Then the next question they will ask is the difference between COPD and emphysema. So these are the standard questions asked in the exam. You must know. What is the difference between COPD and chronic bronchitis and emphysema?
In chronic bronchitis, the mechanism is chronic inflammation and edema. But in case of emphysema, it is an abnormal dilatation of the alveoli without any fibrosis. In bronchitis, the person appears like
emphysema is a parenchymal disease also, not only airway. Okay. Then
in chronic bronchitis, cyanosis would be present. So a person appears due to cyanosis, they are called as blue bloaters. In case of emphysema,
what do you mean by blue bloaters?
Due to chronic inflammation and edema, air cannot come in and out of the lungs. This will lead to a decrease in PaO2 as well as an increase in PaCO2.
So hypoxemia that occur in which conditions earlier, in chronic bronchitis or emphysema?
In chronic bronchitis, hypoxemia would be severe.
Then what happens? So subsequent to hypoxia, what will happen?
There will be a VQ mismatch, and because of that, there is polycythemia, increased erythropoietin.
No, car pulmonary is a consequence. That's why they are called blue bloaters. Bloaters means edema. It is car pulmonary, right heart failure. So consequent to the hypoxemia, there will be increase in the pulmonary vascular resistance and right heart failure. Then fluid retention. So they will be bloated. So it is called blue bloaters. Emphysema, they are called
pink buffer, sir.
So hypoxemia occurs late.
In order to overcome the airway obstruction, they increase their work of breathing by using their accessory muscles. So they appear flushed. So they are called as pink buffers.
Yes, very good.
In chronic bronchitis, you have increased airway resistance, but elastic recoiling would be normal. In case of emphysema, elastic recoiling is lost, but airway resistance is normal. Airway resistance is not seen. PaCO2 would be increased in chronic bronchitis, whereas in emphysema, it appears to be either normal or decreased. Polycythemia is seen in chronic bronchitis and normocythemia is seen in emphysema. A cough associated with copious expectoration is seen in chronic bronchitis. Cough with scanty expectoration is seen in emphysema. Dyspnea severe in chronic bronchitis, dyspnea is moderate in emphysema.
What type of hyperinflation will occur in chronic bronchitis and emphysema?
In hyperinflation is seen in emphysema.
Hyperinflation in emphysema is static. Hyperinflation occurs in the chronic bronchitis dynamic. So every inspiration they can take normally. During expiration, the time is prolonged. Before the end of the expiration, next inspiration comes. So there will be air trapping and your auto, PEEP and your IP. So it is a dynamic during inspiration and expiration. But static hyperinflation, there will be dilatation of the alveoli due to the destruction of the elastic fibers. So the dilatation, so the air, that is the end of expiration, the air inside the alveoli is more. So FRC is increased. FRC is made up of what volumes? FRC.
Expiratory reserve volume and residual volumes.
Expiratory reserve volume and residual volume. Which one will be increased?
Residual volumes will be increased.
Residual volume will be increased. Expiratory reserve volume will be decreased in case of chronic bronchitis. So they have given the patient is having chronic cough, breathlessness, and occasional blood stains sputum. So how will you define chronic bronchitis? How will you come to a diagnosis, clinical diagnosis of chronic bronchitis?
Chronic bronchitis is characterized by increased sputum production and hyperactive airways, sir. The sputum production and cough for more than 3 consecutive months in 2 consecutive years.
Most of the days of 3 months, 2 consecutive years. Okay, very good. So this patient is having cough, breathlessness. How will you classify breathlessness?
According to MMRC classification, sir, Modified Medical Research Classification.
Is there any other classification?
Royson's classifications.
Royson's classification is given in Miller 7 and 8, but in medical literature, they are not using Royson's classification. They are using Modified Medical Research Council classification. Tell me that classification. Raya, that is dyspnea grading.
Dyspnea, grading 0, dyspnea during strenuous activities. Grade 1 is when the person walks uphill, person develops dyspnea. Grade 2, the person works.
Grade 1? Grade
1, person develops dyspnea while walking uphill, sir.
No, hurrying on the flat plane or
grade 2, person walks smaller than others of the same age group. Grade
comparing the walking capacity of one individual with the same age group of another individual. So that is the pace limitation. It is called pace limitation. They are slower than the other participants of the same age. Their pacing is limitation, pace limitations. Then third.
Grade 3, person develops dyspnea while walking for 100 meters. Grade 4, person develops dyspnea at rest.
Grade 3 is the distance limitation. 2 is pace limitation. The third is the distance limitation. Then fourth is the
dyspnea at rest, sir.
Dyspnea even at rest. So breathlessness. Then they give occasional blood-stained sputum. Blood-stained sputum, will it occur in bronchitis, chronic bronchitis?
In chronic bronchitis, it might happen, sir. But mostly it is copious.
Even another clue in the history itself. Patient is diabetes. Diabetes with blood-stained sputum. What do you think of?
Pulmonary tuberculosis.
Yes, commonest in India. Pulmonary tuberculosis. So the patient may be associated pulmonary tuberculosis patients may have. So that's why he has given patient is a diabetic on oral anti-diabetic agents. And is there any CAT score? Have you had a CAT score in COPD? CAT, CAT score. So far we are assessing the patients by objective ways. We are grading the patient severity. There is a subjective way of grading the severity of the COPD patients. So there it is a questionnaires. CAT score is a questionnaire. Give the questionnaires to the patient. And they will getting the cough. They will score the cough 0 to 5. And their sputum production 0 to 5. Then they will tightness of chest. Then dyspnea. There are 8 categories are there. Dyspnea, then patients' limitations of the day-to-day activities, and confidence in venturing out. Venturing out. Then energy level and sleep pattern. So 8 type of questionnaires will be there. They will grade themselves 0 to 5. The ultimate score, if it is beyond 5, it means the patient is having a severe type of COPD. So CAT score and your dyspnea score and the what is called difference. Somebody is talking. Mute yourself. That is acute exacerbation. That also you have to take into consideration. How much acute exacerbation per year you have to take into consideration. So the 3 things: acute exacerbation, your dyspnea grading, and CAT score give a clue about the severity of the disease. CAT score is the subjective, and other 2 are objective. So in what is acute exacerbation of the disease?
It's divided into acute exacerbation is acute worsening of your respiratory symptoms where the patient would require additional therapy.
Symptom worsening and increasing the requirement of treatment. So it may be divided into admission.
Moderate, severe, and very severe.
In admission itself divided into non-invasive respiratory support or invasive respiratory support. So depending upon the occurrence of acute exacerbation, the patient is having a high risk. So they will categorize depending upon the 3: dyspnea, CAT score, and acute exacerbation. Then the patient is having what treatment? The patient is taking inhaler. So what are the treatment for COPD patients? What treatment they will be taking?
Beta agonist, sir.
Beta 2 agonist.
Beta 2 agonist.
Yeah.
Other than that, anticholinergic inhibitor.
So beta 2 agonist, you know the mechanism of action of beta 2 agonist?
Yes, sir. Beta agonist acts on beta 2 receptors. This will increase the adenylyl cyclase, and this adenylyl cyclase will convert ATP to CAMP, and this CAMP can increase the amount of active protein kinase, and that will result in bronchial smooth muscle relaxation.
Very good. So, patient will be taking beta 2 agonist. There are classification of the LABA, SABA, you know.
Short-acting salbutamol and terbutaline comes under short-acting. Under long-acting, salmeterol and formoterol comes under. Regarding ultra-long-acting, indacaterol comes under ultra-long-acting.
Very good. So, any other treatment, beta agonist, then any other inhalation agent?
Anticholinergics can be used, sir, in the form of inhaled inhaler, sir.
So what is that mechanism of action?
Sir, it blocks the muscarinic receptors, both presynaptic and postsynaptic, which would reduce the release of acetylcholine as well as the action of acetylcholine, sir.
So there is M1 receptors and M3 receptors. M1 receptors is responsible for the increased secretion of acetylcholine through the, because the tracheobronchial tree is supplied by vagus. Vagus nerve ending releases acetylcholine. So acetylcholine acts on the M1 receptors. So M1 receptors releases the acetylcholine. M3 receptors, the action of acetylcholine. So it blocks both M1 and M3. Okay. Then any other parental, oral or parental?
Steroids.
Steroids, okay. Steroids are in
xanthine derivatives can be used.
Yeah, xanthine derivatives.
Phosphodiesterase inhibitors.
So what is the mechanism of xanthine derivatives?
Sir, CAM gets converted to 5' ATP with the help of phosphodiesterase. When they inhibit that, the amount of CAMP increases, so bronchial smooth muscle relaxation.
Very good. Cyclic AMP degraded by phosphodiesterase. So inhibition of phosphodiesterase, plenty of cyclic AMP that stimulates the protein kinase A and produces bronchodilatation. So, okay, very good. Then steroids, coming to the steroids. Suppose the patient is taking steroids, what is the implication, anesthetic implication?
Adrenocortical axis suppression would be there if prednisolone is
taken. You have to say hypoxic pituitary adrenocortex, HPA axis suppression.
Okay. If it is taken for 10 milligram of prednisolone is taken for more than 10 days in a span of 10 months, sir. So because of
rule of 10.
Rule of 10.
Rule of 10.
This can cause refractory hypotension intraoperatively, sir.
Okay. So, how will you supplement the steroids in the perioperative period?
Sir, for first we have to see the surgeries, minor, major, or intermediate type of surgery, sir. For minor surgery, we have to continue the preoperative steroid, plus along with we have to give injection hydrocortisone 25 milligram at the time of induction, sir. For intermediate type of surgeries, we have to continue the preoperative steroids, plus along injection hydrocortisone 25 milligram at the time of induction and continued 6th hourly for 24 hours, sir. For major surgery,
early how much?
Continue for 48 to 72 hours, sir.
So 6th hourly you said first to 1 day you have to supplement in the moderate case. How much you have to give 6th hourly? It is 100 milligram per day, 26 milligram 6th hourly, 25 milligram 6th hourly. So it is 100 milligram per day. And severe in major surgeries?
For 40 to 72 hours, sir.
So 3 to 5 days you have to continue per day. How much?
100 milligram per day, sir, or we can give us 25 milligrams.
So it is 100 milligram 6th hourly for 3 to 5 days.
Okay,
induction 100
milligrams, sir.
Okay, okay. Yeah. Then they have used inhaler. He is a known hypertensive patient on regular medications. He is taking telmisartan and calcium channel blocker. Which one you have to continue? Which one you have to stop?
Telmisartan has to be stopped 24 hours prior to surgery, sir.
Why?
It causes catecholamine resistant hypotension intraoperatively, sir.
What is it? It is called catecholamine resistant hypotension. Vasoplegic shock.
Vasopressin can be used, sir, intraoperatively.
So vasoplegic shock patient will have vasoplegic shock in the intraoperative period. How will you treat vasoplegic shock? Suppose this patient comes and you are taking within 6 hours. He has taken before 24 hours the telmisartan. You will land up in vasoplegic syndrome. Shock. How will you treat? Remember, all your catecholamines won't work. Your noradrenaline, everything won't work. You have to go for vasopressin. So that is the drug of choice for vasoplegic shock. Then you can continue.
Nebulizer can be continued, sir.
Continue. Okay. So the patient is also diabetic. So diabetic patient is on metformin and sitagliptin. Which drug you have to stop? Which drug you have to continue?
Both the drugs can be continued, sir. Metformin
you have to continue. Will you continue metformin?
Sir,
What
patient
is the major side effect of metformin continuing in the intraoperative period? You will end up in lactic acidosis. If there is renal insufficiency, there will be lactic acidosis. So metformin you have to stop. Then sitagliptin. What is sitagliptin?
dipeptidyl peptidase 4 inhibitors.
Yes, DPP4 inhibitor. So that should be continued. What is the advantage of sitagliptin? There is no chance of hypoglycemia in the intraoperative period if you are using sitagliptin. So hypoglycemic incidence is very low with sitagliptin. It increases insulin only when there is hyperglycemia. So that is the advantage of sitagliptin. Even you can start sitagliptin in the perioperative period itself. The recent guideline says you can start on the day of surgery also. You can start sitagliptin. That much it is safe. Then they have given the vital signs. Then next you go. So they have given the investigations. So how will you prepare the patient first? How will you do the investigation? What investigation you will do? We will go there. What investigation you will do? Lab investigations.
Complete blood investigation is done, sir.
What you don't say complete investigations. You say hemoglobin, total count. Hemoglobin, how much you will expect in these patients?
Polycythemia would be present, so hemoglobin
It will be more than 15 grams. So will you be satisfied with this high hemoglobin? What is the side effect of high hemoglobin polycythemia?
So the blood becomes more viscous, sir. There is chance of
DVT chances are more. Deep vein thrombosis are more. So you have to go for a VTE prophylaxis. VTE prophylaxis. So this surgery comes under, there are VTE risk score is also there. That is Roger score and Caprini score. Have you heard of Roger score, Caprini score? Based on this patient comes under moderate to high risk. Okay, Caprini score is 0 to 5 and your Roger score is greater than 10. This surgery comes. Mostly major surgical, that is ortho surgeries, come under moderate to high risk surgeries. These patients need pharmacological prophylaxis as well as the mechanical prophylaxis of VTE. What prophylaxis you will give?
The low molecular weight heparin prophylactically we can give, sir.
How much? When will you give?
Sir, 40 milligram of enoxaparin should be given subcutaneous ODs.
How long before surgery?
Sir, since it comes under urgent surgeries, we can give 12 hours prior to surgery, sir.
Full hours, sir. Post-operatively, how much you will continue?
Sir?
What is low molecular weight? It is 30 milligram subcutaneously BD to be continued in the post-operative period. If it is unfractionated heparin, 5,000 units BD preoperatively. Suppose the patient is having HIT. What is HIT? Heparin-induced thrombocytopenia. So if the patient is having HIT, what other drug the guidelines suggest? Fondaparinux.
Fondaparinux.
Yes, very good. Fondaparinux, the dose is 2.5 milligrams subcutaneous once a day. You have to give. So this venous thromboembolism prophylaxis, you must know all orthopedic cases. They will ask. So the risk score also you must know. Roger score and Caprini score. Now, then hemoglobin you have done. Then other
total count is seen, sir, to see whether patient has any infection.
Okay.
Then I look at the renal function test, sir.
Any electrolytes you will do?
Electrolytes, yes, sir.
Which one?
Potassium, sir.
Why?
And if the person is on long-term beta-2 agonist, that might be hypokalemia. That can increase the risk of arrhythmias intraoperatively.
Okay. Then?
I'll take X-ray, sir, to see for the features of COPD.
It's a renal function test because the patient is diabetic. So you have to do your renal function test also. And regarding the diabetes, what will you do? They have given HbA1c 7.2. Is it okay for an elective case? If it is emergency, you said it's an urgent case. How much HbA1c should be there for an elective case? When you say the patient is under control, under control of diabetes?
Ideally, HbA1c should be less than 7, sir.
for controlled diabetes. Okay.
But
It should be less than 8 for a elective surgery.
elective surgery.
Okay. So they have done bedside lung function test. So you know the bedside lung function test?
Yes, sir.
Enumerate the bedside lung
Sir,
function test.
first, I will look at the respiratory rate and also SpO2, sir.
Okay.
Then Sabrosette breath holding test I'll do, sir. Patient is asked to take a deep breath and hold his breath. By using this step, I'll auscultate on his trachea to see when the first early expiration starts. Breath holding time, if it is more than 40 seconds, it is considered as normal. If it is 20 to 30 seconds, the person has compromised cardiopulmonary reserve. If it is less than 20 seconds, person might have poor cardiopulmonary reserve, sir.
So here they have given 25 seconds. What is the inference?
Consider compromised cardiopulmonary reserve, sir.
Any other test?
Sir, Sabrosette single breath count is done, sir. Patient is asked to take a deep breath and hold his
Already said that is. Any other test? Let's say.
Tidus match stick test. Patient is asked to sit comfortably and blow a matchstick which is kept at a distance of 6 inches from him. If he's able to blow the matchstick at 6 inches, then he has a maximum breathing capacity of 60 liters per minute, sir.
60 liters. So what is the normal? So what you are measuring by this Schneider? What lung capacity you are measuring?
So maximum voluntary ventilation.
Maximum voluntary ventilation. So what is the normal for male and for female?
150 to 175 liters per minute is a normal.
So what is MVV, maximum voluntary ventilation? You define that. Sir,
a patient is asked to take a deep breath, that is, take a full inspiration following a maximal expiration for 1 minute, sir. The calculation is for 1 minute, sir.
So the maximum intake of the inspiration or expiration during 1 minute.
1 minute.
That cannot be done in 1 minute. So they reduce to 15 seconds. Because if he does that, what will happen? Respiratory alkalosis will go. He will go. So we are doing for 15 seconds. So normal is 300 to 500 for a female and up to 700 for male. You said it's 60 liters. It is not 60 liters. So 22 centimeter, if he is able to blow without a pursing of the lips. Without pursing of the lips, he is able to blow that flame means he is having 150 liters of maximum voluntary ventilation. He is able to blow only 15 centimeters means 50 liters. So his maximum voluntary ventilation is very low, 50 liters. Okay, then any other bedside test?
Cough test can be done, sir. Green and Barrett's cough test. If patient has adequate cough, if patient has adequate cough, it means his vital capacity is good. It is 3 times the tidal volume. If inadequate cough, it means the FE1 is less than 15 ml per kg, or FEC is less than 20 ml per kg, or PFR is less than 200 liters per minute, sir. And we should see whether the cough is like self-propagated cough is there. If self-propagated cough is there, patient might be having any infection. So post-op-pulmonary complications would be more. Other than that, I'll do PFR, sir, by using a right peak flow meter. Then de Bono whistle test is there, sir.
So do you know the normal value of peak expiratory flow rate for male and female?
For male, it is 450 to 700 liters per minute, and for female, it is 350 to 500 liters per minute, sir.
Any other bedside test?
Wheeze test, sir.
Wheeze
Wheeze test. The patient is asked to take maximum 5 inspiration and expiration, sir. And between the shoulder blades, we can auscultate for any presence of wheeze.
Okay.
Forced expiratory time, we can see. Forced expiratory time. Patient is asked to take a deep breath, and from the start of expiration to the end of expiration, we have to auscultate with the stethoscope. Normal is 3 to 5 seconds. If it is more than 6 seconds, it is obstructive disease. And if it is less than 3 seconds, it is restrictive disease.
And also the height of?
Laryngeal height, sir. A maximum laryngeal height from the thyroid cartilage to suprasternal notch. And
upper border of thyroid cartilage from the sternal notch.
If it is less than 4 centimeter, it indicates an obstructive disease.
Okay. So they have given one X-ray here. Can you comment on this X-ray?
There is Wider intercostal spaces, sir. Flattened diaphragm.
Flattened diaphragm, very good.
Wider intercostal spaces.
Wide intercostal space.
The lung appears hyperlucent, sir.
Hyperlucent. So it is filled with more air.
Tubular heart is seen, sir.
Tubular heart, okay, very good.
Heart. Horizontally placed ribs, sir.
Okay. So what is the inference?
It indicates chronic obstructive pulmonary disease, indicative of emphysema.
It is emphysema, okay. What is Sauber sheath trachea?
Sir, trachea appears narrowed in the coronal plane and widened in the sagittal plane, sir.
Very good. So next slide you put, there is one flow volume loop is there. So pulmonary function test. You comment on this pulmonary function test.
Sir, first I will look into the FE1 by FEC value, sir. From the reference value, it is reduced. It is less than 0.7. So this indicates it is an obstruction.
So that is the diagnostic. Less than 0.7 is the diagnostic.
Yes, sir.
Okay.
Next, I will look into, after that, I will do grading of the obstruction, sir, based on the FE1 percentage of predicted, sir.
What is that criteria?
Gold class.
Pyrometer criteria, gold criteria. What is gold?
Global Initiative of Chronic Obstructive Lung Disease.
Okay. So gold criteria, you grade the criteria.
Here, the patient comes under moderate COPD, sir, according to the criteria.
So this patient comes under moderate. I am asking the gold criteria.
Grade 0 at-risk patient, he has both cough with expectoration. FE1 by FEC is normal, and FE1 percentage of prediction is also normal. The grade 1 is mild, where cough with expectoration might be plus or minus. FE1 by FEC is less than 0.7, and FE1 percentage of prediction.
So in all grades, FEV1 by FEC is less than 0.7. You need not tell. You tell about the FEV1.
Sir, in mild, it is more than 80%. In moderate, it is 50 to 80%. In severe, it is 30 to 50%, and in very severe, it is less than 30%.
Okay, very good. Here TLC is increased. Is it normal or abnormal?
TLC is increased.
Increased. In what will happen in COPD patients? Total lung capacity.
It will be increased, sir.
Okay. So what is DLCO?
Diffusion capacity of lung for carbon monoxide, sir. It indicates the uptake of lungs, uptake of air through the lungs, and indicates the gaseous exchange from the lungs into the pulmonary capillaries.
So here is 52%. Is it okay?
Sir, value is 9.2, sir. 9.2. Normal value is 20 to 30.
So they have given 17.6 ml per mm of mercury per minute. Is it normal? What is the normal value? It is
20 to 30 ml, sir.
18 to 25 is normal. What they do is they will 0.3% of the carbon monoxide in helium. They will inhale the patient and exhale the concentration. Carbon monoxide concentration they will measure. So what is the affinity of carbon monoxide with? So you left out the smoking. So smoking how affects all systems? One by one system it will.
Coming to the cardiovascular system, sir.
First to start with, we are dealing with the respiratory case. So dealing with respiratory system, tell me first.
Sir, smoking itself a most common factor for chronic obstructive pulmonary disease, sir. It decreases the mucociliary function, sir, and it causes hyper-responsiveness of the airways. Then it alters the pulmonary immune functions.
Causes a decrease in surfactant. Alveolar macrophages are affected, so the immune function will be reduced.
Yes, immune function is reduced. So there are two phases, gaseous phase and particulate phase. Here, gaseous phase is carbon monoxide is poisonous to the respiratory system. In particulate phase, there is caffeine is deleterious effect to the cardiovascular system. In carbon monoxide, what it will do? What is the half-life of carbon monoxide?
Sir, it depends upon the mechanical ventilation, the minute volume of the patient, sir. When the patient is asleep, it is 10 hours, sir. When the patient is on rest, it is 4 to 6 hours. When the patient is awake, it is 1 hour. And if the patient is on O2 therapy, it is 40 to 80 minutes. And if he's on hyperbaric O2 therapy, it is 20 minutes. Sir.
So carbon monoxide has a half-life like this. So how it is related to our anesthesia? If the patient is taking a cigarette before the surgery, you have to wait for 4 to 6 hours. Or you supplement oxygen and take it for after 80 minutes. So that will eliminate the carbon monoxide. Because carbon monoxide, what is the effect on pulse oximeter?
Sir, it shows up abnormally high reading, sir. Since oxygen as well as carbon monoxide absorbs wavelength at the same wavelength of 660 nanometers.
It's very good. So it has a 200 times affinity for than the oxygen towards the hemoglobin. So the carboxyhemoglobin will be in the range of 10%. Usually it will be less than 1%. So it will goes to 10%. So it will give you a false high reading. In that case, which pulse oximeter you have to use?
Coaximeter can be used.
Coaximeter you have to. So that will separate the carboxyhemoglobin and your carbon, all other component of the hemoglobin will be separately you can measure in the coax series. It is used only for the research purpose. It is not used in the clinical purpose. Okay. Then your carbon monoxide, then there will be inflammation. Inflammation attracts the neutrophils. The neutrophils cause a release elastase and damage of the your elastic fibers in the alveoli. So the alveoli distended. So your lung complaints, alveolar complaints is increased. So these are the consequences of smoking in respiratory tract. Regarding the cardiovascular system,
Nicotine causes coronary vasoconstriction, so coronary blood flow will be reduced. So there is a risk of ischemia. It also increases the release of catecholamines. Systolic and diastolic BP as well as peripheral vascular resistance would be increased. In carbon monoxide, since the O2 dissociation curve is shifted to left, there will be hypoxia because the offloading of O2 to the tissues will be reduced. Due to hypoxia, that may be polycythemia leading to thromboembolism.
What type of hypoxia that is called? There are 5 types of hypoxia. What type of P50 hypoxia? P50 shifted to the left means delivery to the tissues is reduced. So it is P50 hypoxia. Others are known as ischemic hypoxia, stagnant hypoxia, hypoxic hypoxia. So there are 5 types of hypoxia. This is P50 hypoxia. Okay. Then, so the catecholamine causes increased work of the ventricle. So the work is increased, but the supply is reduced. So the work demand will be disparity. So that they will go for ischemic heart disease. Then GET.
So it causes the relaxation of the lower esophageal sphincter tone, but it usually happens only 4 minutes after smoking, and after smoking cessation by 8 minutes, the lower esophageal sphincter tone will come back to normal, sir.
So as anesthetist, we are concerned about this
aspiration,
relaxation of the lower esophageal sphincter also. So there is a chance for aspiration. So now they have given one. So a cessation of smoking is one of the preparation we will talk about in preparation. So here they have given the volume loop, flow volume loop. So what will happen to the flow volume loop in COPD? Obstructive lung disease and restrictive lung disease. What will happen?
Sir, in COPD, the expiratory curve will be affected, sir. That can be
above the line is expiratory and below the line is expiratory.
Above the line is expiratory, sir.
Very good.
In expiratory waveform, it has a scalloped or a scooped appearance, sir, in COPD.
So the height of FEV1, the height is reduced 1, then it will be shifted to the left because of the total lung capacity is increased. Your residual volume is increased, so the curve is shifted to the left. In restrictive lung disease, the curve will be shifted to the right because all total lung capacity is reduced, total lung volume is reduced, and your height of peak respiratory is also reduced. So shifting of the left and right is the diagnostic of obstructive and restrictive lung disease. Okay, so now how will you prepare this patient for surgery?
Initially, smoking.
How long we can take? Okay, you continue. How will you prepare this patient?
Smoking cessation has to be done, sir.
Okay.
To reduce the effects
How
of
long?
6 to 8 weeks ideal, sir, for an elective surgery.
Oh, for this patient, it is not possible.
Cannot do, sir. Then patient, if any infection is there, we should treat with antibiotics. If patient has any wheezing or respiratory signs, we should treat with more amount of bronchodilators. Patient should be familiarized with chest physiotherapy
Why
exercise.
we are using bronchodilators?
Ipratropium.
To bring out the sputum also. To improve the workup breathing also. We are using bronchodilators. So sputum, how much, when will you say it is a wet lung, when will you say it is dry lung?
More than 100 ml per day.
Okay. So your aim should be in the pediatric period.
Sir?
In the pediatric period, your aim should be how much you have to bring down.
Less than 20 ml per day should be the split to reduce.
Very good. You have to bring down to 20 ml per day. That is the dry. So that all causes, what is the implications? Reduce the post-operative pulmonary complications. So look at how long we can take. Okay. So it is what are other risk index to predict post-operative pulmonary complications?
Ariscat risk index, sir.
What is Ariscat? Do you know?
Sir, 7 criteria is there in sir.
No, what is Ariscat name?
Assessment of respiratory risk in surgical patients with Catalonia.
And what is Catalonia? It is a place in the Spain, Catalonia. So it is so what are the components?
Sir, one is age of the patient, sir.
Okay.
Then pre-op saturation. Then duration of the surgery. Then incision site. Preoperative anemia. Prior respiratory tract infection in 1 month. And emergency surgery, sir.
So points?
Sir, age of surgery, age of the patient is
no, total points.
123, sir.
So more than?
If it is 0 to 26, it is minimal risk, sir.
Minimal risk. More than 25, it is high risk. Okay. Then any other post-operative prediction of post-operative pulmonary complications?
Respiratory failure risk index, sir.
Okay, that is one. And another is Nunn and
Millett assessment, sir.
So these are the. So we can predict the post-operative pulmonary complications with these risk indexes. So how will you prepare? You stop smoking for 6 to 8 weeks, then bronchodilators, then
antibiotics, and then
any vaccination?
Sir?
Vaccination.
Influenza and pneumococcal vaccination.
You have to give. Then
after that,
preoperative respiratory exercise, and also you teach them for the post-operative incentive spirometry. You have to teach in the preoperative period itself. Then, so you prepare the patient. So this is case of closed femur. What type of anesthesia will prefer?
Regional anesthesia, sir.
Why? What is the advantage of regional anesthesia over general anesthesia?
Sir, in regional anesthesia, we can make the patient to ambulate early. Early ambulation helps in preventing DVT, pulmonary embolism, since this patient might have polycythemia, which is a risk for developing DVT. Post-op analgesia would be good. So because of the patient won't have respiratory complications, because his cough would be good. So patient will have adequate cough, so this can avoid post-op pulmonary.
You said regional anesthesia. What regional anesthesia will give?
Sir, combined spinal epidural, sir.
Why not spinal?
So, since the patient is also a geriatric patient, I would like to reduce the dose of spinal, sir. So I would combine epidural. That would help in post-op analgesia.
Okay, so there is no need for a muscle relaxants in this case. If it is abdominal surgery, you need muscle relaxants. You go for spinal anesthesia. For this case, you can give combined spinal epidural. Okay. What is the advantage for epidural in this patient?
I can use it for post-op analgesia, sir.
Very good. Then you are using large volume of local anesthetics.
Yes.
So lignocaine is a bronchodilator. That is an advantage. You are adding adrenaline. That also has an advantage of bronchodilation. And the disadvantage of spinal anesthesia is it blocks the abdominal wall muscles. So the motor blockade will continue in the early post-operative period also. So what will happen? The expiratory reserve volume will be reduced. So the cough effect will be reduced. So there will be stagnation and infection, and there will be hypostatic pneumonia chances of that. So better go for combined spinal epidural or epidural in this case for the post-operative analgesia. This topic is we can discuss the whole day. COPD. Suppose what is the indication for GA in this patient? You are taking the case within 6 hours. Suppose the patient has ischemic heart disease and the patient is on antiplatelet drugs. The patient has taken antiplatelet at 10 o'clock. He is coming for the surgery in 12 o'clock.
I would go
You
for
admitted in the hospital 12 o'clock. You are saying you are going to take the case within 6 hours. So there is no chance for cessation of antiplatelet. Antiplatelet is taken, dual antiplatelet is taken within 24 hours before surgery. So in that case, you have to opt for GA. Any other indication for GA in this patient?
If the patient is not able to lie flat due to breathlessness, if the patient is anxious and having persistent cough where I need immobilization, I would go for GS.
In that case, you have to go for general anesthesia. So general anesthesia, what precautions you will take?
Sir, residual neuromuscular blockade might be present in general anesthesia. Patient may go into respiratory depression post-operatively. So that would reduce his cough. This would increase in post-op pulmonary complications.
So as far as possible, don't stimulate the respiratory tract by very invasive airway. You go for LMA.
Yes,
non-invasive. Okay. Then drugs. What drugs you have to avoid?
Long-acting respiratory depressant drugs should be avoided. So like morphine, pethidine has to be avoided.
So that is opiates. Induction agent.
Propofol is preferred, sir, since it has a rapid onset and it is a good bronchodilator. It causes suppression of laryngeal reflexes. So
muscle relaxant.
I would prefer vecuronium or ocuronium, sir, because atracurium has histamine release, so it can cause bronchospasms.
Or cisatracurium also you can go. But the advantage of giving vecuronium is the reversal agent is sugammadex. So your neostremine also release histamine. So that can be avoided by your sugammadex. And intraoperative monitor, most important is the neuromuscular monitor. Then post-op anesthesia, you have to go combined with regional anesthesia. Suppose the patient is taking antiplatelet, you cannot combine with regional anesthesia. Then you have to go for a PC, short-acting opiates in the post-operative period. Shall we give NSAID in this patient?
Bleeding already, and patient who want antiplatelets. NSAID causes broncho.
So COPD patients.
NSAIDs cause bronchoconstriction, sir.
So their prostaglandin will cause bronchoconstriction. So you have to avoid this non-steroidal antiplatelets. And so you go for a short-acting opiates in the post-operative period. In post-operative period, most important is you have to give the respiratory exercise. What exercise you do? Insert spirometry. You have to give. So these are the way to take up this case. If you say it is an urgent case, they will ask all about the GA. If it is, you say it is a time sensitive 1 to 2, I can wait for 1 to 6 weeks. No, they will ask the elective regional anesthesia. They will ask. So anyway, they will ask this way or that. Okay. Very nice presentation. You have answered almost all questions, and I think you know the depth of COPD. I thank your HOD for teaching you. You are from which college? Coimbatore Medical.
Coimbatore Medical.
All the best.
Thank you, sir.
Over to Selvakumar, sir. Selvakumar? Kriba, sir?
Yeah, I am there.
I finished within 1 hour, I think.
Yeah, it's the right time and a very good discussion. Very good discussion, and the number of attendance is very high for this program. We have touched 160 attendance. Congratulations. Now we will move on to the next session. Selvakumar, please.
Not there.
Selvakumar, are you there? PGs, can you stop sharing the slide? Okay. The other PG is ready now? For instrument discussion? Yeah. He can start presenting.
Who is that other PG?
Sir, she's Kirtana. I think she's
Kirtana.
Kirtana.
uploading the slides.
Yeah. No.
So he is a co-host. She can share her slides.
Yeah. Yes.
Good morning, one and all. I'm going to talk on the topic of laryngoscopes. So, laryngoscopes are the instruments which are used to view the larynx and the adjacent structures. So it is most commonly used for inserting an endotracheal tube into trachea.
Your slides are not moving. Go to presentation view.
Make it full screen.
Presentation view, please.
Is it visualized, sir?
We are able to see, but it is not full screen. Now share. You stop sharing. Share the slides. Yes. Now it's full screen. Go.
One and all. Now I'm going to talk on the topic of laryngoscopes. So laryngoscopes are the instruments which are used to view the larynx and adjacent structures. So it is most commonly used for inserting an endotracheal tube into trachea. It is also used for the purpose of inserting a gastric tube, foreign body removal, and visualizing the upper airway. So there are a wide range of devices available from the simple rigid laryngoscopes to fiber optic devices. So coming to the evolution of laryngoscopes, which is a very interesting field. In early 1880s, the first tracheal intubation was done by Sir Physician William McVeigh and Joseph O'Dwyer, who used metal tubes using fingers as a guide for subglottic edema in diphtheria. So larynx was first visualized by Manuel Braces, who was a singer who used an indirect mirror to visualize the larynx. Then the rigid laryngoscope was first described by Cavalier Jackson in 1907, which had a U-shaped handle with a straight blade and a O-shaped flange. Then in 1930, Janvey designed the L-shaped laryngoscope. In 1941, Sir Miller modification of straight blade was introduced. In 1943, a breakthrough came when Sir Robert McIntosh introduced the curved blade, and which has no substitute for laryngoscopy in normal patients. But it was not suitable for anterior larynx and difficult intubations. Then there was an era of indirect laryngoscopy with mirrors and prisms by Huffman. At present, there is development and refinement of video laryngoscopes, which are majorly used now. So laryngoscopes are the instruments with blade attached to the handle. So they can be manufactured as a single piece or separately detachable blade and handle. So most of them are reusable and it is made up of steel, although plastic disposable versions exist. When the blade and handle are detachable, the source of light is usually attached to a lamp to the blade or the handle in the light with a light guide in the blade. So the handle is fitted with a hinge pin that fits into the base of the blade. So the parts of the laryngoscope, it consists of two main parts, the handle and the blade. And the handle is the part held in the hand, which provides a firm grip and which is used to harbor the batteries. So handles, there are different varieties of handles. There is stubby handles, which are used for obese patients. And there are also pencil type handles, which are used in pediatric patients. And there is a special form of handle, which is called as the petal Syracuse handle, which locks the blade in 4 different anatomical positions, making the variety of angles can be present. So the parts of the blade consists of a tongue, a flange, and a tip. There is a web and there is a base. So the tongue is also called as the spatula, and it's usually the part which is used to compress the soft tissues and depress the lower jaw to facilitate the visualization of the larynx. And the flange is the part which is projects off from the side of the tongue, and it is connected to the tongue part by the means of web. So it serves as a guide for detecting the tissues from the line of vision. So the tip is the end of the flange is called as the tip. So it is used to lift the epiglottis in form of straight blades. And the base is the part of the heel which is used to contact the handle in operating conditions. So the light source may be in the form of lamp socket, which is used to enlighten the illumination. Next, coming to the straight blades. So the basic design of the straight blade consists of a straight tongue and the flange which curves to the right, and there is a curved tip which is used to lift the epiglottis. So Miller blade is one of the most popular straight blades which is still in use, and there is a prototype for straight blade in the present era, as it is a particular part of pediatric difficult airway algorithm. And the main advantage of being the curved tip is used for ideal for elevation of floppy infantile epiglottis, and it is causes better visualization of the larynx. So there are other types of straight blades. The Robert Shaw blade is one of the most popular blades which can be used in infants less than 5 years in children, and it's usually the flange height is very much reduced and the tip is also curved. It's used for elevation of the epiglottis. And the other forms of straight blades are Seward blades, Goodell's blade, and the Wisconsin blade. Coming to the curved blades, Sir Robert Reynolds McIntosh in 1943 first seen the Boyles-Davis mouth gag and soldered a handle to that. So the blade has a curved spatula and the vertical height of the flange is increased, and the flange which is directed to the left. So there are two countries which patented the McIntosh. One is the American McIntosh and the English McIntosh. Usually the English McIntosh, the flange was reduced and the height of the flange is also reduced. So the blade is longer and it is used for visualization of the anterior larynx. So the American McIntosh has a higher flange and it usually ends in the tip, proximal to the tip. So there are also other varieties of McIntosh like improved vision McIntosh and left-handed McIntosh and the flangeless McIntosh, which can be used in varieties of anteriorly placed larynx. So there are flexible tip blades, which is your McCoy blade. The flexible tip blades, there is a hinge tip. It's usually the distal 2.5 centimeter of the blade, which can be flexed by using a lever, which is attached to the handle. And the lever, when it is pressed away from the handle, it is used to flex the tip. So it is usually a modification of McIntosh blade, which is available in various sizes. So when the lever is activated, the tip flexes and it elevates the epiglottis, which improves the Cormack and laryngoscopic grading, and it forms a part of difficult intubation cart. Due to the minimal cervical manipulation, it can be used in cases of unstable cervical spines. So there are also blades with special functions like tull blades, which has suction sport. And there is also a special blade, which is called as a polio blade, where the handle and the blade makes an obtuse angle. And it can be used, first it was invented in cases of use for obese individuals, kyphoscoliosis, and patients with barrel-shaped chest. So the technique of usage. So as we all know, the optimal positioning for laryngoscopy is 35-degree flexion of the lower cervical spine and 85 to 90 degrees extension at the atlanto-occipital joint, which is our popular sniffing position. So the laryngoscope is held in the gloved left hand and the fingers of the right hand are used to open our mouth using the scissor technique, and the blade is inserted at the right angle of the mouth and the flange helps to push the tongue to the left side. So then the blade is advanced along the base of the tongue. The blade is advanced along the base of the tongue until the epiglottis is visualized and the tip is positioned in the vallecula. Now a force should be oriented at 45 degrees, which is away from the laryngoscopist, indirectly lifting the epiglottis. And always the vector of the force should be the deltoid and the triceps, and it is not by the radial flexion of the wrist. So this technique of usage is popularly used when the curved blades are used. And for straight blades, we usually use the paraglossal laryngoscopic technique, which was developed by Sir Dr. Henderson. It provides maximal tongue control. Here, the scope is inserted lateral to the tongue and advanced below the tongue and in the paraglossal area between the tonsillar fossa and the tongue. On further advancing, the epiglottis comes into the view. So the optimal position for the tip of the straight blade is in the midline, which is posterior to the epiglottis. And at this time, there is you can use an external laryngeal manipulation, can improve the view where you apply backward, upward, and rightward pressure on the thyroid cartilage. So coming to rigid indirect laryngoscopes, and in the past eras, the prisms have been used to refract light to bring the laryngoscope view into the vision. So it is a form of indirect laryngoscope, and there are popular prisms like Huffman's prism, Bell scopes, and prism views. So indirect fiber optic laryngoscopes. So usually the fiber optic laryngoscopes are used as an indirect method to visualize the larynx. They are anatomically curved blade, which is they have 3 working channels and 2 working channels for a light source and then viewing the image bundle. And usually the blade is curved up to 90 degrees and there is a thumb lever which is activated and it's used for intubation and suction. So the advantages of rigid indirect laryngoscopes can be difficult intubations, morbidly obese patients, and minimal cervical movement is sufficient for because the alignment of oral, pharyngeal, and tracheal axis is not required. So now the video laryngoscopes, the Canadian surgeon Pacey has incorporated a miniature camera or under the side of the blade for glide scopes, which has led to the era of video laryngoscopes. And there is a blade has a 60-degree angulation beneath the midpoint. An image is transmitted to the monitor. So there are several varieties of video laryngoscopes available like CMAC and ARTRAC and the McGrath. So the cleaning and sterilization recommendations, cleaning procedures include washing the blade and there is a liquid chemical sterilization. Laryngoscope should be stored under clean conditions and disposable covers that fit over the handles and blades are made available. As soon as possible, after each usage, the blade should be rinsed and immersed in water and enzymatic detergent and thoroughly and gently washed with brush with attention to around the bulb area. So blades may be sterilized with ethylene oxide or steam plasma or treated with liquid chemicals. So the complications of laryngoscopy are usually dental injury. There may be damage to teeth, gums, or dental prosthesis causing disfigurement and discomfortment, and pulmonary complications if fragment is aspirated. So upper incisors are mostly involved because teeth are used as a fulcrum point for laryngoscopes, which should be avoided. And damage to upper airway includes abrasions, hematoma to lungs, tip, palate, pharynx, and larynx. So increase in airway-related complication increases with number of laryngoscopy attempts increases. So laryngoscopes results in increased blood pressure and increase in heart rate. So laryngoscope malfunction can also happen as a result of defective power source, lamp or socket, or poor operating conditions between the blade and the handle. So it is always advisable to check the laryngoscope before usage. And cervical spinal cord injury may happen when there is aggressive head positioning in unstable cervical spine patients. Thank you.
What's your name? Kirtana. Hello, Kumar.
Yes.
Thereafter, you insist them to which textbook they have taken that test. Figures are the points. So at the end of the slides, every slides they let them from which textbooks they have taken reference. So it will be useful for the PG and all other PGs.
Yes.
Yeah.
Yes.
They should not study from the internet.
Yeah.
Nice presentation, Kirtana.
Thank you, students and Edward.
Please stop sharing the screen.
Yeah, the biggest advantage of this ISATN webinar is time. 1 hour we can discuss, and no other place we can discuss a case for 1 hour. Even in our college, when we start discussing the time limitation, even in exam, they given just 30 minutes. So 1 hour discussion is an advantage for the PGs. And also equipment. So this simple equipment, what we use daily, when you are asked some simple question in the exam, most of them, they blink. Especially this controversy of straight blade. Dr. Kirtana, the straight blade of Miller, everybody says that it is used to lift the epiglottis. Yes, it can be used. It doesn't mean that curved blade cannot be used to lift the epiglottis. Both the blades can be used to lift the epiglottis. It is not the type of the blade it matters. It is the type of epiglottis in children. It is hanging and quite large. So it obstructs your view. In the vallicula, if you go and lift, the area epiglottic fold is not strong. So when you are going into the vallicula and then lift as in adult, the epiglottis will not come with your laryngoscope. That's why it hangs and obstructs your view. So it has to be cleared to see the epiglottis. And it is funnel shaped. Funnel shaped means glottis will be in the distal end, not like in adult where immediately after lifting the epiglottis, you will be able to see the cards. But in children, it will be distal, 1 centimeter down, and it is a funnel shaped one. So naturally, your view will be the epiglottis will be obstructing. So it has to be clear. Whether you do it with the curved blade or straight blade doesn't matter. Miller is not designed for it. The main advantage of Miller in children is the absence of flange. So if there is a flange, you need a very big mouth opening. As you know, in children, the mouth opening will be limited. So if it is just a Miller blade without flange, you can easily introduce into the mouth. But with the flange, you need a quite big mouth opening, and then you have to insert it with difficulty. That's why. Otherwise, Miller blade is excellent in insertion and lifting the epiglottis, better than curved. Just that you have to use Miller for lifting. Miller biggest disadvantage is tongue holding. As in curved blade, the tongue holding will not be there in Miller. Especially when you are new to Miller blade, you will be finding very difficult to hold the tongue in the lateral position. And tongue will keep on coming to your view to obstruct the view. So Miller is not that easy. Keep used to it and then try to hold the tongue beautifully. And if you keep it in the midline Miller blade, then the tongue will not come to your view. This is a smaller tip. Anyhow, well done. You have prepared nicely and all the... yes, please.
May I ask one question to Kirtana? Kirtana, what is the height of the flange? Have you ever measured the height of the flange? It is 3 centimeters. That's why we are, when assessing the airway, we are saying mouth opening should be 3 centimeters. So we have to introduce the flange. So Solomon mentioned its flange is the
Reduce flange.
disadvantage in that is advantage in Miller than the Macintosh, because small mouth opening. Nowadays, with video laryngoscope, they come with D blade. Have you heard about the D blade? There is no flange in the blade.
Flange.
It is without flange. So small mouth opening we can introduce. So the flange height is more important, 3 centimeters. That's why we are assessing the mouth opening should be at least 3 feet.
It's a very good point. Why you are insisting on mouth opening of at least 3 centimeters, the flange height, right? And especially in cleft palate, when there is a gap, when your flange enters into it, you will not get that space. That's why introducing the tube will be very difficult in a cleft, especially left side at cleft palate. Yes, over to Dr. Kribakaran.
Yeah, there is one question in the chat box. Edward, please look into it.
So the video laryngoscope, if it is with the flange, there also we need 3 centimeter mouth opening. There is one blade, that is D blade, that is less than 1 centimeter. It is around 1 centimeter mouth opening we can introduce. That is mainly for difficult areas. That's D blade. For all other video laryngoscope, you need 3 centimeters mouth opening. This conventional blade, hyperangulated blade. There are 2 types of blades in the video laryngoscope: conventional blade and hyperangulated. Hyperangulated blade, there is one variety, it is called D blade. There is without flange, the height is around 1 centimeter. In that case, you can use for a difficult mouth opening.
Okay.
Yes,
another question is there.
Yeah.
Another question is there.
So look, my McDosey blade, what is?
What is that question? I am not able to see.
McDosey blade.
Can you read out the question, please, sir?
McDosey blade. What is McDosey?
Question is not incomplete. Sorry, yeah. Question is incomplete.
McDosey blade was an invention done by our own Indian anesthetist. He was marketing there in earlier
all the conferences.
Yeah. The advantage he claims is edentulous patient, it's easy. That's what he used to tell. I haven't used, even though I have bought one, but I haven't used.
Okay. So there are no more questions, sir.
Yes, sir. You can take over, sir. Yes.
Well done. Well done, all the postgraduate students, and congratulations to the Department of Anesthesia of Coimbatore Medical College for training the postgraduate students very well. Congratulations to Shanmugavelu and Sendilnathan and the entire team of Department of Anesthesia. And congratulations to our academic chairman, Dr. Selvakumar, because he was aiming to touch 120 attendees. But this program we have touched 160 attendance. So congratulations. Next month, we are coming out with the neonatal anesthesia with the postgraduate students from Kanyakumari Medical College. So another important announcement is we are going to have our state conference at Erode. The registration is going on, and all the free paper and poster presentation registrations are going on. Please keep in touch with the Erode ISA people for your participation and the registration for the conference. Thank you. And
Sir, sports betting to leading, sir.
yeah. And like last year, we are also going to have a Tamil Nadu ISA sports meet. This time we are going to conduct Pan India sports meet because a lot of other state people are also participating. So we are going to have it in Dindigul in June month. So you can get the information from your local secretary. And if you are willing to participate, you can give your name. We are going to conduct 6 games in the sports meet. So we have made elaborate arrangements for the sports meet. Our vice president is organizing this sports meet. So you can touch with Dr. Rajkumar of Tirunelveli ISA for your participation in the sports meet. So now over to Coimbatore ISA secretary for branch report.
So I think they are not available.
He's not there.
Yeah, he's not there until yes, sir.
Yeah, then you can take over Shamil Velu for vote of thanks.
Okay, right. Thank you. So actually, last time that time was around 90 only. I think this time we are touched really 150 to 160. It's a very good improvement, sir. Okay, sir. So for that, I thank our state president, sir, Dr. Girubaran, sir, and our academic chairman, Dr. Silvakumar, sir, for this IS webinar. And I also thank Dr. Edward Johnson, sir, for being the examiner. Thank you, sir. Thank you very much. And I thank all my speakers, Dr. Nisha, and Jaikumar, and Kirtana. And also,
Yes, sir.
You are muted.
Thank you, everybody. Kriparan, sir, you can wind up the meeting, sir.
Right. Thank you all.
Thank you, sir. Thank you all. Thank you all.
Thank you. We will meet next month. Thank you. Bye.
We'll meet in the next month, which will probably on 27th. Thank you.
Yeah. Okay. Thank you. Bye.
Shilpa, we can close the meeting. Shilpa? Okay, now கூப்பிட்டு சொல்லிடுறேன்.